presented with the jaundice, high liver enzymes and Kasher-Flasher ring, what is the most proper treatment? So concentrate. They are not asking about the diagnosis. They are asking about the treatment. So just let me remind you, gentlemen and gentle ladies, that they ask you 3 questions in exam. Either they will ask you need to know the 3 things, then your knowledge would be much better, right? You need to know investigation, you need to know how you diagnose, and third thing is the treatment. So here they are asking the treatment, so that means you have to do 2 jobs here. What is the diagnosis, then you jump to the treatment, right? So what is the diagnosis, then the treatment? So options of the treatments are British anti-lewisite, penicillamine, desferrioxime, and acetylcysteine, and none of the above, right? There is nothing in the treatment for this patient, right? So just think over it. Anyone can wants to speak quickly, right? Let me know in just 5 seconds. You can unmute and speak. What's the answer? We are 39 participants in the hall, so if anyone wants to speak, speak it. Fine. If don't, then I'll go ahead. So this is a copper. Excellent, penicillamine. Excellent, wonderful. So this is a penicillamine. How come penicillamine? Right? A young boy present with the jaundice. Why jaundice? Because there is a liver dysfunctions and there is a deposition of excessive copper in the liver. At the same time, it developed in the lens or the eye near the cornea and sclera. That is KF ring. We shortly known as KF ring or Kasher-Flasher ring. This is the pathognomonic of copper poisoning. Right? So copper poisoning, what is the most appropriate is a penicillamine. Desferrioxamine is for what? That you also need to know. That is for iron overload or iron poisoning, and N-acetylcysteine is for acetaminophen poisoning, right? So this is how you need to remember, right? So KF ring, until proved otherwise, it's a Kasher-Flasher ring, means copper overload, and the treatment is penicillamine, right? This is the chart of all the poisoning, what commonly they asked in the exam. So I try to posted it here, all the things, right? So acetaminophen, right, is a N-acetylcysteine, anticholinergic, anticoagulant, vitamin K, calcium channel blocker, blah blah. So I will share with you, right? So you should keep in mind all these things. So we will get back to you, right? That's it. This is what the explanation is, right? Great. So this is what the chart is. Next questions. This is what the things. It is a copper poisoning. In case of suspected copper poisoning, penicillamine is a drug of choice, and dimercaprol, a heavy metal chelating agent, is oftenly administered. Kasher-Flasher rings are the dark ring that appears to encircle the iris of the eye, and they are due to the copper deposition as a part in the cornea, right, as a result of particular liver disease. The early stage may be detected by slit lamp examination before they become visible to a naked eye. So it's an excellent explanation. So you just keep in mind, they may ask you, I had given the example of this copper, they may give you iron, they may give you magnesium, they may give you lead, they may give you acetaminophen. Again, very interesting but confusing questions for you guys. So it's in the emergency room, burns patient. So just have a look at it. A 43-year-old woman is brought to the emergency department after being burned in a house fire. You estimated that the first degree burns of 20% of her body, second degree burns of 11% of her body, and third degree burns is 9% of her body. She weighs around 60 kg and 160 centimeter tall. What IV therapy would you begin immediately to this patient? Options are ringer-lated 200 ml per hour for 24 hours, normal saline 400 cc per hour for 24 hours, normal saline 150 for 8 hours, then 75 for 16 hours, RL for 300 for 8 hours, and 150 for next 16 hours, RL for 600 for hour for 8 hours. Then after 8 hours you can do it, right? This 300 cc for next 16 hours. So just think over it. What is the logic? How you calculate these things? Extremely easy formula that I will tell you. that is called as a Parkland formula. Just keep, if you remember the Parkland formula, you will never miss out these questions. 100% you can hit these questions answer, but you must remember the Parkland formula. They won't give you right things, so they will give you such a little tricky thing. They may give you right the different scenarios for burns, but this is the bottom line. If you know the Parkland, you can answer it. Anyone quickly, just 5 seconds, any questions, answer. Anyone open? We are 38 participants.
300 ml Rungalex for first 8 hours, and after 150.
Let's see.
Yep.
Yeah, so let me tell everyone, this is the Parkland formula, gentlemen. So mug up, fix in your head what is the Parkland formula. So Parkland formula, right, is this formula. Write down 4 ml, right, 4 ml multiply by, right, percentage of total body surface area, right, multiply by patient's weight in kg, right, that the final amount should be given in 24 hours. So now if you want to calculate, right, calculate now, just there is a one catch in this scenario. Never calculate the first degree burns. Never calculate. First degree burns is not in the IV fluid calculation. So 20% is gone. Second degree burns is 11% and the third degree burns is a 9%. So 11 plus 9 is a 20%, right? So 20%, keep in mind, first degree burns is not counted. First degree burns is not counted, right? So second degree burns is 11 and third is a 9. So 11 plus 9 is the 20% burn. So let's go to the things. 4 ml multiply by 20 multiply by weight in kg. So write down in your notes 4 multiply by 4, right? Sorry, what 4 ml, write down 4 ml multiply by percentage of burns. How much? Second degree is 11 and third is 9, so 20%. So 4 multiply by 20 multiply by 60 is equal to total amount. So how much is the total? 4800, I guess, right? 4800, right? So 4800 means 400, half in first 8 hours and half in the last 16 hours, right? So 2400 half multiplied by 8 means 300 ml per hour for 8 hours, and after that it's different. So Ringer lactate 300 ml per hour for 8 hours, then 150 ml for 16 hours. That is the answer. Consider second and third degree burns in the calculation of fluid resuscitation. Do not count first degree, which is here, right? Just to confuse you, right? And formula, as I told you, weight in kg multiply by percentage of burns by 4, total 60 kg weight. First and second degree, 11 plus 9 is 20, multiplied by 4, 4800, divided in 24 hours, right? So if you calculate in first 8 hours 2400, that is half amount, and half in next 16. So 8 hours 2400 ml means in 1 hour 300 ml. So look for the 300 ml in the scenario. So this is the scenario. So 300 ml in 8 hours and next in the 16 hours. Is that clear to everyone? Yes or no? Please quickly, yes or no? I tried my level best to make it simplified. Yes or no? Is it okay, everyone? Going well?
Yes, sir.
Yes, sir. Yes, sir.
Wonderful.
Yes, sir.
Brilliant people. Next questions. A 35-year-old man with the known history of peanut allergy. Each and every word in MCQ is extremely important. If you learn the art of reading the MCQ, believe me, nobody will beat you, because we are so in hurry to give the answer that we cannot read the questions properly, believe me. And that is the biggest major fault. I taught thousands of doctors so far. This is commonly, right? Before, reading the question, they are looking for answer ABCD. Don't forget about ABCD. Look at the question, make an impression. What is the investigation? What could be the diagnosis? What could be the treatment? Ask 3 questions to yourself for every MCQ, then you are a master, believe me. So apply this formula here. 35-year-old man with the known history of peanut allergy present to the emergency department with the swollen face. Examination, the blood pressure is 85/60, pulse rate is 120 per minute. There is a bilateral expiratory wheeze. or bronchi? What is the most appropriate form of the adrenaline to give? So first of all, you need to make a diagnosis. Can anyone tell me quickly what's the diagnosis for this patient? Quick, anyone?
Anaphylaxis.
Anaphylaxis.
Excellent. So complete answer is
Anaphylactic shock. Anaphylactic shock.
excellent. So complete answer is anaphylactic shock, not just the anaphylactic. Why? Because if you look at the blood pressure, it is a shock blood pressure. Again, tips from my side. Any blood pressure less than 90 considered until proved otherwise, this patient is in shock. So in your clinical practice or in your emergency room, any patient comes with less than 90% of the blood pressure, consider there is some kind of shock. Then differentiate hypovolemic shock, hemorrhagic shock, anaphylactic shock, cardiogenic shock, septic shock. Which shock? That is the second story. But first you identify shock, right? Why anaphylactic? Because keep the second thing. They may sometime ask you the diagnosis. They give you the scenario. They ask, right? Which shock is this? Hypovolemic, anaphylactic, septic, cardiogenic, what? Right? So this all clue, I will give you the clue right away. So whenever there is an anaphylactic shock, there must be some kind of 100% history of exposure. Either it is a peanut, or it is some meat, or it is some chemotherapy agent, or it is some sulfa drug or something, right? After exposure to that agent, the patient developed the shock. Now go back to the history, right? The 35-year man, right? History of peanut allergy. So he has a peanut allergy, right? History of peanut allergy present to the emergency department, right? So he must have taken the peanut, right? That is the exposure history, and it is common, very common with peanut, X, right? And examination, you see classical hypovolemia, yes. Tachycardia, yes. Hypoxia, yes. Even though it is not given in exam, this is a classical, right? There is a hypoxia plus expiratory wheeze because of bronchospasm, because of the hypersensitivity to airway, bronchi, trachea, and bronchi, right? That is the pathophysiology of this. So that is why this patient has a bilateral extensive and expiratory wheeze. So this is a classical pakka case of this anaphylactic shock, right? So how do you treat? What is the treatment of choice? So it is 10 by 1s 1000, 1s 10,000, 0.5, 1s 10,000 IM. You are confused for this. What to do? Anyone quickly in 5 seconds? What's the answer?
B. B.
Great. So fix in your head. Fix in your head. B. All right. B 0.5 ml. If sometimes they give 5 milligram, don't get confused. 0.5 ml is equal to 0.5 milligram, because 1 milligram 1 ml and 0.5 milligram 0.5 ml. This is what the standard dilution in the ampule. Go and check to your crash cart in your emergency room or your in the ward. There must be a one crash cart. So go and look at the adrenaline. It is 100% there in your floor, right? So 0.5 ml, right? But what's the dilution? 1s 1000 only. Where you use this 1s 10,000, not one. It is used in cardiac shock or cardiogenic shock, right? Or cardiac arrest, right? IV, sorry, 1s 10,000. 1s 10,000 is used. I will give you the difference. But this thing is 3 things. Write down in your notes. It is not given here. Please write down. Anaphylactic shock MCQ comes. There must be a history of exposure to some agent. Number 1. Number 2, drug of life-saving drug in shock is adrenaline or epinephrine. Write down. Many people are confused. What is adrenaline? What is this epinephrine? So adrenaline and epinephrine both are the same thing. It's a synonym, so don't get confused. Adrenaline and epinephrine both are same. So one thing is that there is a history, another is adrenaline or epinephrine is used. 100% it is intramuscular. Don't get confused. Dilution is right 0.5, 1s 1000. Remember, 1s 1000 intramuscular. Which is the side? 4 question. Intramuscular where? The best preferred side is a lateral wall of thigh. Write down lateral wall of thigh, right? So this is the things, right? And what other drugs on top of this you can use? Another drug you can use is diphenhydramine. Write down, right? And another is hydrocortisone. So these are the 3 saving drugs in any anaphylactic shock. One is adrenaline or epinephrine, both are the same thing. Another is Avil or chlorpheniramine maleate or diphenhydramine, that is anti-allergic, antihistaminic, which is the responsible for bronchospasm, hypotension, and peripheral vasodilatation, right? And third thing is this, right, is the drug, right? So this is what you need to remember, right? Intramuscular, right? And it is in the lateral wall of thigh, right? So this is what they ask in the exam. They won't ask many hi-fi things, right? So I had given you already the whole idea. Intramuscular, these are the high yield points. I'm just making it with a red pen. So intramuscular 1s 1000, maximum 0. Frequently should be repeated. So if you had given one dose of epinephrine 0.5 1s 1000 intramuscular lateral wall of thigh, if no response to the patient, still BP, blood pressure, oxygen and respiratory rate is same, you can repeat after 5 minutes again, say another dose. That's it. And this is the biggest difference, right? Write down what is the dose in CPR. Epinephrine, same drug. Epinephrine and adrenaline, same drug. Don't get confused. In either here anaphylaxis, it is intramuscular, CPR intravenous. Second difference. Here 1s 1000 is here 1s 10,000. Here intramuscular, here intravenous. Right? Here 0.5 ml or mg. Here the double dose 1 milligram. Here every 5 minutes, same. Here you can repeat every 5 minutes. That's it. This is what the bottom line difference is. So if you understand this difference, right, they ask you epinephrine in anaphylactic shock, they may ask you epinephrine in this department of CPR. So don't get confused, you can answer anything, right? So I'm not wasting the time going ahead.
For each question, already we are 4 minutes late, so with ado, we go to the questions. Okay, number one, you are responding on an ambulance to a wedding where the elderly father of the bride has collapsed while dancing. Bystanders say he was complaining of chest pain earlier, but didn't want to mess up the celebration by going to the hospital. He was dancing when he suddenly lost consciousness and fell to the ground. Bystanders have done standard CPR. You arrive and place the patient on the monitor. It shows sinus bradycardia, but the patient has no palpable pulse. CPR continues with high quality compressions and ventilation. You have established IV access. The only drug appropriate in this scenario would be 1, atropine, B, lidocaine, 3, epinephrine, and D, amiodarone. 10 seconds, everyone, to think and give the answer. Okay, I'm seeing mostly C's, so let's talk about it. Okay, so here, technically when the patient is unresponsive and you see no pulse, it is the ACLS algorithm you should follow, okay? This is the ACLS algorithm from Oxford Handbook of Emergency Medicine. So this is the ultimate algorithm, okay? So here you see they call resuscitation team, they're doing CPR, you assess the rate. There is no pulse, it's not VT, it's not VF, so it's not shockable. Here you have pulseless electrical activity, okay? So in pulseless electrical activity, you do CPR, and here in the drug part, you see, you give adrenaline 3 to 5 minutes, and here it says give amiodarone after 3 shocks. So it is only for shockable, for VF and VTAC. So as you can see, this is the only drug that you see. Adrenaline or epinephrine is the only drug you see in this algorithm. So here, yes, you have pulseless electrical activity. So the only drug that you're allowed to use in this setting is epinephrine. Thank you, everyone. Okay. So here you see how the epinephrine works. There are 3 mechanisms for epinephrine, and this is the only drug you're allowed to use in this setting. Okay, next question. You're working in a coronary unit, taking care of an elderly female who was admitted 48 hours earlier with the diagnosis of acute inferior anterior wall MI. She had placed in her LAD, but has not done well. Her husband runs out of the room and tells you that my wife doesn't look so good. You find her to be lethargic, pale, and diaphoretic. Her blood pressure is 60/42 and her pulse is 30. Question, the monitor reveals following rhythm, this. So what is this? Option A, second degree AV block type 2, B, sinus bradycardia, C, second degree AV block, and D, third or complete degree heart block. 10 seconds, everyone, give me answers. Okay, great. I'm seeing mostly these. So let me take you to the heart, to the conducting system of the heart. This is the heart, okay? This is the SA node. It creates action potential, okay? So when the action potential moves all around the atrium, you have atrial contraction, which is the P wave, okay? So here it reaches to the AV node. In AV node, you have a physiological delay. Why? Because we don't want the atrium and the ventricles to contract at the same time. So here you should have a delay before it goes to the ventricles, okay? So if you have more than a physiological delay in AV node, you have AV node block, which has type 1, type 2, and type 3, okay? Complete block and not just a delay. What is happening is that the SA node creates its own action potential and all the atriums are contracting due to that action potential. But since this is a complete block, one other spot in the ventricle is going to come up and start creating action potential, and the ventricles are going to contract due to that, okay? So what happens is that that atriums and the ventricles are contracting completely separately, okay? This is what you see here. This is a P, this is a P. Again, here, you see there is a little different of the shape of the T waves. It's because sometimes P waves fuse into that, okay? So you have P wave, P wave, P wave, all regular and with the same interval, and you have QRS, 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 all with the same. As you have a complete heart block, atriums and ventricles are working separately, okay? And you see the patient has a bradycardia, has a low blood pressure, all due to complete heart block. This is where you see other blocks. This is a normal, this is a first degree block, which is increased PR interval. Second degree blocks, you see there is two types. We're going to talk about it later. And you have third degree or complete heart block. Complete heart block always needs a pacemaker, permanent pacemaker. You need to insert for the patient. And what do you see after you inserted the pacemaker? This is what you see. You see a spike, a sharp spike exactly before each QRS. You see this little spike, this little spike. This is the spike that the pacemaker is producing. The heart to go into normal number of contractions. Okay, next questions. Number 3, while you were treating your patient, you forgot about her husband who was standing in the room watching. He now says he's dizzy and falls to the floor. He's breathing spontaneously at a rate of 18 per minute. You quickly check him and find that his skin is cold and clammy. His pulse is 40 per minute. You quickly put him on a portable monitor, and this is what reveal. What is it? A, atrial fibrillation, B, complete heart block, C, sinus bradycardia, and D, sinus tachycardia. Give me answers. 10 seconds, everyone. Okay, so I'm seeing mostly C's. Thank you, everyone. Yeah, as you can see, this is a sinus bradycardia. Not every collapse is a cardiac problem, okay? So yeah, this is a sinus bradycardia, and usually there is no treatment needed. As you can see, other options are atrial fibrillation. In atrial fibrillation, you shouldn't have P's, you shouldn't have clear P's. So as you can see, we have really beautiful P's here, clear cut, so no atrial fibrillation. Any relation between P's and QRSs, but here clearly you see any one QRS after each P. So no complete heart block. Sinus bradycardia is the right, and sinus tachycardia, obviously not tachycardia, because as you can see, the patient has bradycardia. So this is sinus bradycardia, no need for doing any cardiac intervention or any drugs or anything. No, but about other blocks, as we talked about earlier, like second degree type 1 or type 2. In type 1, you have progressively increasing PR intervals, but in Mobitz type 2, you have, without any order, you have some P's that don't go through to the ventricles. Okay, I have here ready for you. Second degree type 1, use this long two lead to understand second degree type 1 block. Okay, as you can see here, you have a PR interval here, it increases here, increases here, increases here, and here we have one P which is not followed by a QRS, okay? So again, here from the top, if you look at this PR interval and this PR interval, these two look the same, because you have once again from the top this cycle, okay? Again, progressively increasing until you have one QRS one P not followed by a QRS. Okay, this is second degree type 1, usually doesn't need any direct intervention for this block, but as you can see here, sometimes it's due. Here you can see an ST segment elevation in the leads 2, 3, and AVF. So this block is probably due to an inferior wall ST elevation MI. So here you have a second degree type 2 mix, okay? So here you have again increasing here. So here you have one P which is not followed by a QRS, it's not conducted, okay? So if it was and one more P which is not conducted, okay? So this is second degree block type 2. This is dangerous, and in all cases of blocks, which is either it's like type 1, type 2, you have to check if the patient doesn't turn into higher degree blocks, but you have to do a pacemaker because you know, the patient, because it's dangerous, it might go to complete heart block. Your next question. You're called to the home of a 48-year-old woman whose chief complaint is, I almost fainted when I got out of bed. She has been ill for 2 days with nausea, vomiting, and diarrhea. She had a temperature until this morning when it finally broke. She feels dizzy when she sits or stands up. Her skin is cool and clammy. Her color is pale. Her pulse is 130. Her blood pressure is 88/64, and her respiration is 80 per minute. Pulse oximeter reading is 96% on room air. She has no medical history. So here is her ECG. The options are 1, atrial tachycardia, B, ventricular tachycardia, C, atrial 10 seconds, everyone, give me answers. Okay, thank you. I'm seeing mostly these. So yeah, here you have normal sinus rhythm. This is sinus tachycardia and sinus bradycardia. As you see in the sinus tachycardia, you have P's, you have QRSs, you have T's, everything is normal, just tachycardia, okay? So yeah, this is sinus tachycardia. Sinus tachycardia happens due to a reason, okay? Either the patient is anxious, they're having like a panic attack, they're having like, sometimes they're having a thyrotoxic problem, okay? So sinus tachycardia, this patient is clearly hypovolemic, okay? So sinus tachycardia, the heartbeat is usually around 100, 150. Usually it's not more than 150, okay? And you have to treat the reason. There is no cardiac intervention needed, okay? This patient is hypovolemic. You just give them IV fluids or PO fluids. The patient's going to be fine, okay? So no problem there. You do not do anything for the sinus tachycardia. Okay, next question. You are in the emergency department when a 54-year-old man arrives rubbing the center of his chest. He states, "It feels like someone is sitting on my chest." His radial pulse is strong but fast. His blood pressure is 130/80 with a pulse oximeter of 92% on room air. He has no past medical history and takes no medication except for paracetamol for an occasional headache. He has no allergies. You take him back to a room, place on the monitor, and gain IV access. Question. His monitor strip is like this, okay? So options are A, atrial flutter, B, third-degree heart block, C, normal sinus rhythm, and D, atrial fibrillation. 10 seconds, everyone, give me answers. Okay, so I'm seeing mostly C's, and that's the correct answer. Thank you, everyone. Yeah, technically, this is a very, very common scenario. A patient comes to you with a pain, chest pain, it might be even cardiac, but you see normal ECG or even normal troponins. This is a very, very common scenario. Normal ECG doesn't mean the patient doesn't have a cardiac problem. It just means for now, it's fine, okay? For now, there is no conducting problem in the heart, or there is no ischemia that you can see in the ECG. Doesn't mean the patient doesn't have a cardiac problem, okay? So yes, this is a normal sinus rhythm, okay? So you have to do like more investigations and more things for this patient. Sinus rhythm. Someone said atrial fibrillation. For atrial fibrillation, you shouldn't have clear P waves. Here you see clear-cut, beautiful P waves, okay? So whenever you see a clear-cut P wave, there is not AF, okay? It's not AF, okay? It's a normal sinus rhythm. So you complete a 12-lead ECG, and the results are shown like this ECG, okay? The options are STEMI, anterior lateral wall infarction, unstable angina, STEMI, inferior wall MI, or normal ECG. This is what you see. Give me answers, everyone, 10 seconds.
Can you show the ECG, ma'am, once?
ECG.
Can you see that?
Yes, it's clear.
Okay, and this is the options.
Share the option, ma'am.
Sure. A, STEMI, anterior and lateral wall infarction. B, unstable angina. C, STEMI, inferior wall MI. And D, normal ECG. Okay, thank you, everyone. I'm seeing mostly A's, and that is the correct answer. Yes, this is. So how can we know that? Okay, so here are the adjacent leads. Lead V1, V2 is the septum. Okay, lead V3, V4 are anterior, and lead V5, V6, 1 and AVL are lateral wall, and 2 and 3 and AVF are inferior wall. Okay, so where do you see the ST segment elevation? Okay, you have at V3, V4, a little V5, clearly 1 and AVL. So what is this? This is an anterior wall ST elevation MI. What do you do in this patient? You send for troponin and CKMB, but you do not wait for the result, okay? Because in this case, the patient has an STEMI. You have a limited time to do revascularization, okay? You have to give the patient aspirin, clopidogrel, atorvastatin, morphine for the pain, antiemetics, and you have 30 minutes to do revascularization by drugs, or 90 to 120 minutes to do PCI, okay? So if you want to wait for the troponin, so troponin even may be negative for the first time. So if you want to wait for the patient to have a positive troponin, so you be positive it's an MI, you're gonna lose the time and the patient might die, okay? So no, in this case, ST elevations or new LBB, you do not wait for the troponin results. Other options are unstable angina. In unstable angina, you have non-specific changes. You may have ST depression or T-wave inversion. No, it's not unstable angina. Clearly, you have ST segment elevation in these leaders that I named. So the next question. The patient is placed